Good afternoon, everyone. Okay, so we're just setting up the projector for a second. So next we're going to start our question and answer session. So it's going to be half an hour. We are privileged to have Dr. Epstein with us today, so please seize this opportunity and ask your question. But I would like to ask you please to raise your hand and introduce yourself before you ask your question. Thank you. Okay, so please, if you have any questions, anyone?
Thank you, sir, for the excellent presentation. We really thoroughly enjoyed it. I am Dr. Rajan, consultant from one of the ministry hospitals. It's called Farvania Hospital. We are a general hospital, and we cater to a lot of GU cases. I encountered a case a year back in which the morphology was completely oncocytic, and they had the round nuclei. We did the stains also, but I saw some tubules which were entrapped in between the oncocytic islands. And the another problem with that case was, like we always, as you pointed out, that they should have a myxoid stroma and should be the nest. So the myxoid stroma was missing. It was very, like tubular and lobular, mostly nests, and with entrapped kidney tubules. So if you can shed some light, I don't have any molecular on that case. So we called it an oncocytic neoplasm, and like you said, in your lecture.
Yeah, oncocytic lesion tumors typically will not have entrapped normal tubules in it. The one situation where you can see sometimes normal renal tubules within an oncocytic lesion is an oncocytosis. You'll have normal tubules in there. So that's a potential, but it's obviously difficult without seeing the slides. There could be a lot of potential entities.
The normal tubule should not be there, no?
Yeah, normal tubules should not be in an oncocytoma, right? And basically, any of the oncocytic tumors, you shouldn't see normal tubules entrapped in a lesion like that.
And it had a lot of degenerative atypia, so does it point towards benign thing?
Typically, it would be more of a benign lesion, okay. Right? Yeah.
Thank you.
Hi, Dr. Epstein. I'm Karen. I work at Kuwait Cancer Control Center, and I have two questions for you. The first one being, recently we dealt with a prostate core biopsy, and maybe 4 out of the 6 cores that we received showed a Gleason score 3+3=6. However, one of the cores showed maybe 3+4=7. That's what half of us thought of, and the other half thought it was a 4+3=7. So my question to you is, the 4 that was there, the pattern 4 that was there, did not show cribriforming. It showed like poorly formed glands, and it wasn't even at the 50% mark. Maybe around the ones that thought it was 3+4, the pattern 4 was around 20 to 30%, whereas the ones that thought it was a 4+3, they presumed it was more than 50%. Now, in such a case, when we are dealing with a core and there is a clear-cut discrepancy among the agreement among all the pathologists, how do we handle a case like this? Because it has treatment implications. And that was the main point of concern. Because the surgeons were like, if you guys call it a 3+4, we will just do active surveillance. Whereas if you'll call it a 4+3, then we will go ahead and treat the patient. So it becomes a big problem in such a situation. And the repercussions henceforth, if they do decide to treat it and they don't decide to treat it. So how should we handle such a case?
Yeah, so at least in the United States, it would be handled by somebody who would sending, for example, me a consult, and we would deal with it. I'm willing and very happy to take consults on an occasional basis. We don't charge from overseas. So if you have cases that are critical for patient management, Again, I'd be definitely willing to look at it. It's a very common situation where people have problems where there's differences in grading. I would probably say, of the cases I see in prostate biopsy where patients send me their consults, because often patients or clinicians will ask the consults sent to me, I'll disagree on the grading maybe 20-30% of the time, because there can be difficulties in grading, no question about it.
But if he cannot send a consult to you at that point in time, is it okay to overcall? Like, what would your suggestion
I would probably
be?
say, again, if you're not sure, I would undercall. Because you don't want a patient overtreated. I'd rather the patient be, in a sense, undertreated, and then they can maybe add treatment later if something happens. But once you overtreat somebody, if they have complications from that overtreatment, you can never go back. So, that's now. Eventually, there may be even AI, artificial intelligence, that is being developed for grading, which may be an adjunct. But currently, that's not something that is out there that I would recommend. So currently, the best is, just to show it to others who have other expertise. And also, like I've said before, sometimes doing levels can help to kind of clarify, what's poorly formed versus not poorly formed.
Okay, and my second question is, in your experience, do you think a pan-keratin immunostain would help to find pattern 5 when it is difficult to distinguish on an H&E?
Yeah, so if you're not sure about pattern 5, better than a pan-keratin is a CAM 5.2, the low molecular weight keratin. There's sometimes prostate cancers can be negative for keratin, like an AE13, a pan-keratin. Sometimes high-grade prostate cancers may be negative, whereas a CAM 5.2 will always be positive.
But do you use it for finding pattern 5s in the cores?
No, I don't use it I only use it when I'm not sure if it's cancer versus inflammatory or stroma. But if it's a matter of obvious cancer, I don't use keratin stains to see is there 5 or not.
Okay.
I would say rarely I might if I wasn't sure some crushed cells were 5, for example. But I would say for the vast majority of the time it's an H&E.
Thank you.
Sure.
Just a few paper I read, some of the people, when they have a grade 5+5 cancer, solid sheets, they see some granules. They are regularly doing synaptophysin and chromogranin to rule out a large cell kind of a neuroendocrine carcinoma, which should be differentiated from a normal 5+5 because they should not be graded and treated separately. Do you do it on all high-grade cancers?
Yeah, so that's a good question. So the question in terms of looking for neuroendocrine differentiation in prostate cancer. So the issue with prostate cancer is that if you were to take usual prostate cancers, 3+4, 4+3s, 3+3s, and stain them with synaptophysin and chromogranin, you will see a large percentage of those tumors will have neuroendocrine staining, and it means nothing. So you have to be very careful doing neuroendocrine staining in prostate cancer and over-interpreting it to mean it's neuroendocrine carcinoma. So it's a very difficult, sometimes differential diagnosis between 5+5 and small cell or large cell neuroendocrine cancer. So when I'm not sure of that differential, I do a battery of immunostains. So I do prostate-specific markers. So I do PSA. As I mentioned, we also have P501S and NKX3.1 prostate markers. So those prostate markers should be negative in large cell neuroendocrine cancer and small cell carcinoma. I do a Ki-67. It should be 70, 80, 90% in small cell cancer. In high-grade prostate cancer, typically even 5+5, 50% or less. I do a stain for RB, retinoblastoma. You lose RB in small cell and large cell neuroendocrine cancer, typically maintained or retained in usual prostate cancer. Also do TTF1, the lung marker. It's positive in 50% of small cell carcinomas and large cell neuroendocrine cancers of the prostate. It's always negative in 5+5 = 10. So, and probably the most important thing is the prostate markers, because if you think something is small cell carcinoma or large cell and it has fairly good prostate markers, it's not large cell or small cell. Now, there are some rare cases where something looks like 5+5 and it has prostate markers, but it's diffuse synaptophysin, like 100% or 90%. We don't know what that means. So in those cases where it has both prostate markers and diffuse synapto, I will end up saying, we can't call it small cell, we can't call it large cell neuroendocrine because it still retains prostate markers, but this may be a tumor that's basically in transdifferentiation, kind of halfway going towards like a small cell carcinoma or high-grade neuroendocrine cancer. And basically what I recommend in those patients is they treat the patients for like regular prostate cancer, typically anti-androgen therapy. But if the tumor doesn't respond, maybe then they should consider treating it like a small cell carcinoma or a large cell neuroendocrine cancer. But prostate is, the whole issue with prostate cancer and neuroendocrine differentiation is more difficult in prostate than other organ systems because most other organ systems, lung cancers, bladder cancers, don't express neuroendocrine markers in their usual cancers, whereas prostate does. The other thing that makes prostate cancer, I think, more difficult is that in prostate cancer, we see these tumors that are kind of halfway between usual prostate cancer and small cell cancer, kind of in the process of transdifferentiating, where they have half and half features, which I think makes it much more difficult. We don't see that in other organ systems. But you have to be very careful because I know of cases where people have overdiagnosed small cell cancer and patients have gotten toxic chemotherapy and had problems. And then I know of places where people have underdiagnosed small cell cancer and they didn't get also the right therapy. So it's a difficult, it can be a very difficult diagnosis. But I would say if something really looks like usual prostate cancer, don't do the neuroendocrine stains because then you're going to get into trouble trying to interpret them.
Dr. Epstein, I'm Dr. Naqib. I'm working in Kuwait Cancer Control Center. I recently had a specimen of radical prostatectomy, and it was involved, about 30% of the gland was involved by the carcinoma, and it showed only one focus where the tumor, there was maybe just a small cluster, a small nest of tumor, which was beyond the confines of the prostate gland. Okay, it was not involving the prostatic fat. It was just pushing outside the normal outline of the prostate gland. So when I did deeper levels, the tumor was more, and then it showed involvement of the neurovascular bundle. So I called it positive for extraprostatic extension. But if I would face a situation in future in which there was no more tumor on deeper levels, and it showed only just a small nest or a small gland outside the normal outline of the prostate, can I still call it extraprostatic extension?
Yeah, so that's a good question. It can be very difficult in prostate to determine extraprostatic extension. Every day in our own institution, our other pathologists who are very good pathologists show me those cases. So part of it is, it depends where you're looking in the prostate when you're trying to decide what's extraprostatic extension. So if you look posteriorly, posterolaterally, and laterally in the prostate, it has a fairly well-defined edge to the prostate where the condensed muscle ends. So to call extraprostatic extension in that situation is when the tumor goes beyond the condensed muscle. You don't have to see it in fat. As long as it's beyond the muscle of the prostate, sometimes in loose fibrous tissue, that's out of the prostate, extraprostatic extension. Anteriorly, there is no edge to the prostate. So anteriorly, you have to see tumor in fat to call it out of the prostate. And at the apex, it's very, very difficult to decide if tumors in the prostate or out of the prostate, because at the apex, the boundaries are very ill-defined. The normal prostate, benign prostate glands are actually in skeletal muscle at the apex. So down at the apex, it's almost impossible to tell what's in or out of the prostate. And then up at the bladder neck, you can call it extraprostatic extension when it's in the thick muscle bundles. Then you can call extraprostatic extension. Also, when you call extraprostatic extension, you want to separate out focal extraprostatic extension versus non-focal because the latter has a worse prognosis.
Hi, Doctor. I'm Dr. Lavi from KCC. So actually, same question I have for the extraprostatic extension on a core biopsy. Sometimes on a core biopsy, like we find like little bit of fat and with 1 or 2 clusters of tumor cells, and then, it's in the middle of the core. And then we see the skeletal muscle, and then we see again the prostatic tissue. So if we find the tumor like that, we don't know like how the biopsy is taken. So in that case, do we call it positive, or we have to correlate with the MRI findings?
Yeah, so on a needle biopsy, so basically there are extremely rare situations where you can have a little bit of fat in the prostate, but it's very rare and very focal. So if you see cancer on a needle biopsy and it's in fat, at the same level of the fat, you can say there's extraprostatic extension, because the likelihood of that needle biopsy hitting very rare foci of intraprostatic fat, in my opinion, is almost impossible. So anytime you see cancer and fat together on a needle biopsy, you can say there's extraprostatic extension on the biopsy.
Thank you.
Excuse me? Yeah, I wanted to ask you that just when you were explaining about atypical intraretinal proliferation, and that we can have peripheral basal cells showing prominent nuclei. So sometimes in the prostatic biopsy, you can have basal cell hyperplasia and a tangential cut in which you can see prominent nuclei in multiple layers. So in that case, how can we differentiate that from atypical intraretinal proliferation?
Yeah, so with basal cell hyperplasia, the architectural pattern typically is abnormal. It's usually multiple small crowded glands, so it actually mimics more infiltrating prostate cancer. But with basal, sometimes you can see basal cell hyperplasia in a bigger gland, which can also be confused with AIP. The difference in that case is you don't, typically when you have basal cell hyperplasia with prominent nucleoli, you almost have very scant cytoplasm. It's usually you've lost a lot of the cytoplasm and piling up of the basal cells, whereas AIP you tend to have cells with more abundant cytoplasm in contrast to just proliferation of basal cells. But also if you're not sure, you can do the high molecular or basal cell stain. Because with basal cell hyperplasia, you'll see multi-layering of the staining, and you'll see that the atypical nuclei with the prominent nucleoli are labeling, for example, with high molecular weight keratin. Whereas if it's AIP, what you see when you do a basal cell stain is you'll see a very flat basal cell layer with a high molecular weight keratin, where the flat layer has no atypia. You can barely see the nucleus. It's just a flat little crescent. And then with the AIP, the nuclei with the prominent nucleoli will have no basal cell staining. It'll be totally negative for basal cells. So that can be a helpful way to distinguish the two.
Anyone else?
Hi, doctor. This is Dr. Maram Al-Wazam from Amiri Hospital. I have one question for you. If there is a cribriform high-grade pin in a prostate biopsy, do you prefer calling it as such, or only we call it like atypical proliferation?
Yeah, so if something looks like cribriform high-grade pin on a biopsy, and it's either going to be typically intraductal cancer, I would call it, or AIP. Depending if it's dense cribriform, that makes it intraductal cancer. If it's big open spaces, I would call it AIP. But yeah, in general, I would never, I used to, but I don't anymore, call cribriform high-grade pin on anything. Yep. Sure. And it's important now because, as I mentioned, now for the most part, when urologists get a biopsy from a biopsy high-grade pin, they often now don't do anything about it. They're not worried about it anymore. Whereas intraductal cancer, they would definitely be worried. And I think the problem with AIP is I think it's a new concept and urologists are not familiar with it. So if you diagnose something as atypical intraductal proliferation AIP, you have to put in a comment or talk to the urologist and explain to them what it means, saying that this could be intraductal cancer. It doesn't fully meet the criteria. And it's something that probably should get a repeat biopsy because it's just not something that urologists are going to know what it is.
Hello, Dr. Epstein. I'd just like to ask you whether we need to grade an adenocarcinoma with aberrant P63 expression.
Yeah, it's a good question and sometimes a difficult question. So the tumors that show aberrant P63 staining, most of them actually behave in a fairly indolent pattern, prognosis, more comparable to a 3 + 3 = 6. But morphologically, many of them look more like pattern 4, often poorly formed glands. So there's a disconnect between what they look like and the grade. So in many of these cases with a barren P63, I don't give them a grade. And what I end up saying is that the grade, most of these tumors behave better, less aggressively, and their grade may inaccurately reflect how they will behave. So I don't assign a grade. I have seen some, rarely, P63 aberrant cancers that are overtly high grade, extensively solid areas, and those I don't give them a Gleason grade, but I just call them high grade and say the Gleason system may not apply to the P63 aberrant cancers. But a lot of them I don't give them a grade.
Just a small you told that we give percentage for the pattern 4. So sometimes you see in a core biopsy, the edges are at the glands are at the almost sort of edges. So do you give it take it 10 plus 10% of the total, or the in between normal glands should have to be included in that core? I hope you are getting the
sure. Yeah. So when we measure the cancer, sometimes you will see discontinuous cancer, for example, on a biopsy. You may have a little bit of cancer on one edge, maybe take the extreme, a little bit of cancer on the other tip of the core, with all intervening benign tissue. What has been shown is that in 85%, 90% of these cases, when you see a little bit of cancer on one end, a lot of benign tissue, and then a little bit of cancer, it's the same tumor going in and out of the plane of section as opposed to two separate or multifocal tumors. So when I give how the extent of the cancer on the biopsy, I say where the cancer starts and where the cancer stops, and including the benign tissue in between. Now, in cases where there's a lot of intervening benign tissue, the terminology I use to match the histology is, for example, I will say small foci of Gleason score 3 + 3 = 6, prostate cancer discontinuously involving, for example, 80% of the length of the core. But that is in the United States, it's not uniformly done. So that is a problem. For example, I might get a consult where somebody had said there's 10% of the core involved because they took two cores, the cancer with a little bit on one area and another, and they just mentally put it together, 10%. And I'll sign out that same case as discontinuously involving 80% of the core. And a patient gets the report and says, how can one pathologist call it 10%, one pathologist call it 80%? But that's the reason.
Thank you. Thank you.
Excuse me, Dr. Epstein, just one other question. Any clarification regarding the term the atypical small SNR proliferation, which is often used, and sometimes in core biopsies we can get or all of the core biopsies will turn out to be benign, but you can get less than 1%, maybe 1 or 2 or 3 glands which are a little suspicious, and they're not pattern 3 looking glands, they're losing the Bayesian marker. So for that, what terminology is suggested? Is it good to report them, not report them, or what is your take on this?
Right. So if you see something atypical that you might do the stains, you might not do the stains, that you're suspicious as cancer, but you're not 100% diagnostic definitive for cancer, you definitely should report it, because studies have shown that about 40% of those patients, there will be cancer on repeat biopsy. Some urologists, as I mentioned, may do the repeat biopsy. Some may decide just to follow the patient with imaging or serum tests. But you definitely want to flag those patients as having something atypical so that they're not potentially lost to follow up and not followed carefully. I don't use the term atypical small SNR proliferation. I use the more descriptive small focus of atypical glands and then the note that I use. But either one is appropriate. I think the most important thing is to convey to the urologist that there is something there that's not definitive for cancer, but you can't be 100% sure that it's not cancer, and therefore you want that patient to be followed carefully. And there are some cases where, you may have 2 or 3 cores, 3 or 4 parts that are atypical, and so it's not uncommon. And again, some cases, if I look and I see just 1 or 2 glands that are atypical, I won't do the special stains because I know no matter what, I'm not going to be able to make a definitive diagnosis. I'll just call it atypical. There are some cases I'll say mildly atypical, cases that I favor it's benign. And then there are other cases at the other end of the spectrum I'll say highly atypical for cancer, but I still can't make a definitive diagnosis.
Dr. Epstein, in a prostatic biopsy, only in one site, if one core is showing just 2 or 3 glands, but which are showing all the features in a mental balance sheet, if we say that, yes, these glands are showing all the features of carcinoma, but the glands which are showing the carcinoma are just 1 or 2 in the entire biopsy, then can we call it adenocarcinoma?
You can call it if you're 100% sure it's cancer. Again, typically in that scenario, with just a few glands, the most common scenario that I will feel comfortable calling those cancer is when those glands are tightly packed in between benign glands, so I know it can't be high-grade prostatic intraepithelial neoplasia. Because the one thing that can mimic limited cancer is high-grade PIN, just being a tangential section. But if those glands are situated in an area where you could not have high-grade PIN tightly in between benign glands, then even with just a few glands, yes, you can call it cancer.
Thank you, Doctor.
We recently had a kidney case. I know we've not discussed the staging of kidney tumors, but we had a kidney case in which there was a completely encapsulated clear cell renal cell carcinoma bang in the renal sinus fat. It was completely encapsulated, but it was within the fat and it measured around 3 to 4 centimeters. So how would we stage this? Would this be a T2 depending upon the size? Or because it was in the renal sinus fat, would we call it a T3?
So there was no component in the kidney?
No. In all the sections that we took, it was only within the fat.
Yeah, that's very unusual. I can't say I've ever seen such a case. I've just never seen a kidney cancer
But
not being in the kidney.
The point of contention was because it was completely encapsulated, none of the cells were actually touching the fat. So normally when they say you want to call it a T3, the cells have to either be adjacent to the fat or...
Yeah, so one thing that can happen, which might have been the situation that you're talking about, there are some cases where you can have a renal cell cancer rising just from the outer cortex. So it looks like it's not in the kidney. It's arising from the most outer cortex, and then it protrudes into the fat as a rounded nodule. So 99.9% of the tumor is bulging into the fat as a round nodule. In that scenario, if it's a low-grade lesion and it's a perfectly round surface to it, I would call it T2.
Thank you.
Sure.
We have time for one more question.
Just one thing I would emphasize for staging of renal cell cancer is it's now recognized that when the renal cell cancers invade out of the kidney, they typically do at the hilum. That's also where you see renal vein segmental branches of the renal vein involvement. So for any cancer of the kidney that's anywhere near the hilum, you want to put through 4 or 5 sections of the hilum looking for vascular invasion and extension into the hilar fat.
Just an observation regarding FH deficiency, HLRCC related renal cancer. I saw the case. It was very nice with the prominent eosinophilic nucleoli. Was the case had patient any leiomyomatosis in the uterine leiomyomatosis or in the skin? You showed one case of HLRCC related.
Yeah, I'm not sure in the case that I showed whether that patient had the stigmata of HLRCC or whether it was sporadic. I'm not sure.
Because we had a couple of cases of FH deficiency which could not be confirmed by only morphologically we suspected FH deficiency, but molecular testing was not done, or either immunohistochemistry.
Yeah, one thing I would stress is if you're doing a fair amount of renal pathology, is to consider getting the FH antibody and the SDH antibody. They, again, straightforward immunohistochemistry. There's nothing, unique about those antibodies. They're straightforward immuno, just like any other antibody. Those I would recommend getting along with CA9, and most people have c-KIT or CD117. I think, and again, consider cathepsin K, because diffuse cathepsin K suggests translocation-associated RCC. Those are kind of some of the major, maybe newer markers to consider for getting for kidney tumors.